What is up, YouTube? Welcome back to another video with medicine with AUNO. This is lecture 2. We're going through patients with back pain and trying to figure out what different pathological conditions they may have. So in this video, first video on this, we talked about muscle strain in an overview video. So go back and watch that if you haven't. This video we're going to talk about spondylolisthesis, spondylolysis, and spondylosis, also called spinal osteoarthritis. And break these three things down. Next video, we're going to go into one of these things. I forget which one it was. But anyway, so let's break down the word. Prefix spondylo. What's this mean, y'all? Spine or vertebrae. And then listhesis. That refers to slippage. So slippage of the vertebrae or spine. Lysis, to break, crack, or fracture. Split, from chemistry, biochemistry. We know that term. So you're cracking or fracturing the vertebrae. Spondylolysis. Osis is a pathologic condition, so this is going to be a pathologic condition of the spine, right? Also known as osteoarthritis, specifically vertebral osteoarthritis or spinal. Degenerative disc disease is basically damage caused by age-related wear and tear of the joints of the spine, and this can occur from many different causes. And spinal osteoarthritis is the most common cause of spondylosis. So we're going to start off discussing spondylosis. The most common cause is spinal osteoarthritis, which we said, well, let's break that down. This is due to age-related wear and tear of the vertebral column, and it usually affects the intervertebral disc and the facet joints. If I pronounce that right, I have no clue. Y'all go comment down below something random for me. Here's a healthy spine. Here's an osteoarthritic spine. You can see some bone spurring, narrowed intervertebral disc spaces. So this is basically, again, spondylosis, a pathologic condition of the spine. It's kind of generic, non-specific term. So we said that this condition is most common in the cervical and lumbar spine. And when cartilaginous implates will break down, which is number 3 here. So this is our cartilaginous implate of the intervertebral disc. And that begins to break down. The bones will begin to rub against each other, leading to bone spurs and osteophyte formation. So we can see cartilage here. This is on the facet joint. And this can break down, leading to this condition where we have degeneration. This is what happens. Degenerative intervertebral disc. Calcification of the implate, which is in green. Here's the cartilaginous, well, actually it might be purple. No, green, cartilaginous implate, nucleus pulposus, subchondral plate. So cervical versus lumbar spondylosis. Here is a cervical spine. You can see these long spinous processes. You can see torn, thinning disc, bulging disc, herniated disc. Just degenerative disc disease can lead to these complications, right? This spondylosis is kind of the most basic issue here. So we'll see decreased height of vertebral body. This is lumbar spine, bone spurs, blah, blah, blah. So causes of back pain. I mean, never mind. I don't know why I just said causes of back pain, y'all. Okay, cervical spondylosis, because we're not talking about the causes of this. We're going to break down cervical spondylosis and lumbar spondylosis. Hang with me, y'all. We're getting through this. It's going to get good, though, near the end, so stay with it. Most commonly presents as neck pain. One of the leading causes of disability and rising costs of health care today. It encompasses a wide range of progressive degenerative age-related changes that affect all components of the cervical spine. Disc, facet joints, primarily, also ligaments. It causes narrowing of the spinal canal and intervertebral foramina, which can lead to compression of the spinal cord, spinal vasculature, and nerve roots. Now, lumbar spondylosis is also a degenerative process affecting the disc, vertebral bodies, and/or associated joints of the L spine. It's shown radiologically by joint space narrowing, osteophytosis, cyst formation, and subchondral sclerosis. And we're going to look at that. So there's this degenerative cascade where you get this dysfunction phase, microtrauma, tears, then instability phase, loss of mechanical integrity, and then stabilization phase with disc space narrowing and fibrosis along with osteophyte formation. So you can have some axial neck pain with cervical spondylosis, cervical myelopathy, and cervical radiculopathy, shooting pain, some numbness, tingling, loss of sensation. With lumbar spondylosis, we're going to see pain within the axial spine due to these nociceptive pain receptors within facet joints, intervertebral discs, sacroiliac joints, nerve root dura, and those can send pain, lead to pain. So also you can develop spinal stenosis due to ingrowth of osteophytes. When we have a patient here, we want to ask duration. How long has this been going on? So with both of these conditions, cervical and lumbar, it can be acute, recurrent, or chronic pain. The onset can be insidious, slowly progressive, or acute onset. The course of symptoms, usually they'll just, I think they will worsen without treatment over time. The degeneration will get worse usually. Characterization, so in the neck, you have the neck stiffness, cervical spondylosis, pain in the neck, severe radiating pain to back of ear or occiput versus into superior trapezius or periscapular muscle, respectively. Occasionally electric shock types of symptoms, paresthesia, weakness in arms and hands. Over here in lumbar, you can see dull to severe radiating pain, could develop hypoesthesia, loss of sensation, or weakness in limb. Location, usually, it can be either unilateral or bilateral neck pain. It can be radiating pain, as said, and urinary symptoms more rarely, extremely rare with cervical spondylosis. And again, these are when complications arise, right? Location here, low back pain may radiate down the lower limb. Aggravating factors, neck hyperextension and lateral bending, increases pain, stiffness in cervical region, most severe in upright position, head tilt to the affected side, can cause shooting pain down a limb, right? And here with lumbar, you'll see activity worsens it, of course, twisting, bending of the back. Relieving factors for both is bed rest or rest. Especially this one's bed rest, because if the neck's elevated, that's putting pressure on the cervical spine. So laying your neck down helps the pain. Associated symptoms can have radicular pain, myelopathy, shooting pains, weakness of hand, gait instability, unexplained falls, and rarely urinary incontinence. Over here, associated factors, symptoms, develop radicular pain or numbness, weakness of lower limb. And again, radicular pain is just basically radiating pain down a limb, right? Down the nerve root or nerve dermatome. Pertinent risk factors, older age. Same for both, really. Heavy lifting and proper lifting technique, previous back injury, high contact sports. Ask the patient if they have any concerns and prior evaluations. Okay, so examination of these patients. It's the same thing, I think. Or no, maybe I just didn't find one for this. But anyway, cervical spondylosis, hyperextension and lateral bending will increase pain. Head tilt to affected side can increase radicular pain. Neck can be stiff and mobile at head and neck. Tender trigger points are frequently present within superior trapezius muscles, cervical paraspinal muscles, or periscapular muscles. The Sperling test can be positive if there's radiating pain propagating to an upper limb. When extension of the head with head rotation on ipsilateral side, which is to the affected side. Positive. So yeah, if you have the pain, extension of head, then rotation on the same side of that affected side. And positive for cervical radiculopathy, if this is positive. And check bilateral extremities for strain sensation. Check deep tendon reflexes to identify if there's compromised nerve roots or myelopathy. Okay, so imaging. Now we're getting to the fun stuff. So plain radiograph, X-ray C-spine, L-spine. It's an appropriate imaging study. In absence totally misspelled that, right? How do we spell abs? Whatever, in absence, there's a C in there, right? I did not win any spelling bees back in the day, y'all. There's absences, there we go. I did not win any spelling bees back in the day. Actually, I might have won one in like junior high. I'm not sure. I wouldn't win one today, obviously. But in absence of a red flag symptom, because then you want to pursue MRI first, right? But you can see osteophyte formation, disc space narrowing, end-plate sclerosis, degenerative changes of the neurocentral and facet joints, or calcified ossified soft tissues. So here's a degenerative C-spine. You can see some bone spurs, these anterior little growths off of the vertebral bodies. And then you can see a narrow disc space right here at what? This is C2, C3, C4, C5, C6, I think. So C5, C6. I believe this is C7, but I might be wrong. I think this is the axis and atlas up here. So on here, this is a coronal x-ray. I think there's osteophyte formation seen on the edges here, these vertebral bodies. And you can see osteophytes here. So degenerative changes, some narrow disc space. This is lumbar spine, and this is a cervical spine. MRI is usually not needed, but it does allow for best evaluation of neural structures, soft tissues. CT provides good definition of bone structure. It's more sensitive than plain radiograph, of course. And CT myelogram can be done as well in EMG. So now we're moving on to spondylolisthesis. That was kind of long, but hang with me here. We're getting into the stuff. This is when complications may arise. So this is a condition in which one vertebral body slips. So the first condition, spondylosis, is just a broad statement of there's some degenerative back, spine, vertebral, spinal disease, right? This is when we actually know what's going on. This is specific, a slippage of one vertebral body with respect to the adjacent vertebral body beneath it, which causes radicular or mechanical pain and symptoms. So we can see how this L5 has slipped over S1, okay? And that's grade 4, that's the worst. It can be congenital, acquired, or idiopathic, and is graded based on the degree of slippage as seen here. Most common is in the lumbar spine, second most common in the cervical spine. Degenerative spondylolisthesis can occur from spine degeneration without any defects. So you have this degeneration, right? That's what we talked about first, spine degeneration. So it can occur from that without any defect in the pars interarticularis, which we will talk in the next section, the spondylolysis. Usually related to combined degeneration of facet joint and disc, leading to instability and forward movement of one vertebral body over the one adjacent to it. So we see that it's moving anteriorly over this S1. So, other types of spondylolisthesis can be caused from defects in the pars interarticularis, spondylolysis, which we'll discuss. Trauma fractures of pars interarticularis, which we can see actually here. Congenital, from variation of facet joint orientation, bone or connective tissue disorders, infection, cancer, and iatrogenic causes. So here is a fracture here, and this has some, well, I don't know if this is slippage yet here or not, but there's a pars defect. We'll look at that. So in pediatrics, 90% of these are L5, S1. In adults, most are L4, L5. Right? So this is what okay. L4, L5 in adults rarely is greater than 30% slippage, which we saw is about, rarely is more than this in adults. And it usually affects, if this happens, it can affect the L5 nerve root, right? And you can see that here where this nerve root can be compressed. Because if this slips forward, this drops down, right? And this will compress the nerve root because it won't be supported. It'll just drop. So when you have a patient here with back pain, let's find out what they might have. So duration of symptoms, again, acute, recurrent, chronic pain. Depends when they show up to the office. Onset's insidious versus acute, again. Course, intermittent low back pain or neck pain, pending spondylolisthesis location. Characterization, low back or neck pain with potential for radicular pain, shooting pain down limbs. Location, low back, neck. Localized with potential to radiate down limbs. Aggravating factors, activity, flexion, or extension of affected segment, and palpation of affected segment will cause pain. So tender at the level of the spondylolisthesis. Lying down on your back will help relieve the pain. Associated symptoms can develop radicular pain, as we said, with lumbar involvement, buttock pain, numbness or weakness in legs, difficulty walking, rarely bowel or bladder symptoms, saddle anesthesia, and quad equina syndrome. Pertinent risk factors: older age, female, obesity. And patient concerns: what are they worried about? Prior evaluations. Here's a pars defect, broken bone right here at the pars area, which we'll get into. Physical exam and imaging: pain exacerbated with flexing and extending affected spinal segment. Pain exacerbated by palpation. It's tender. AP and lateral radiographs, as well as lateral flexion extension, can see abnormal alignment of one vertebral body when compared to the next, as well as possible motion with flexion extension to indicate instability of the spine. Here is anterior protrusion of L4 over L5, and this appears to be about 30%. If we look at our drawing here, it appears to be about 30%, 40% slippage. And there's no pars defect. And here there is a pars defect. So this is called the Scotty dog collar. Our professor taught us about the Scotty dog sign or whatever. But when you have the collar, it indicates, it shows like a little collar thing. It's a lucency here. And, you know, look at this one. Here's the pars interarticularis. It's all pretty much same. But here there's like a splitting. Here it's all kind of the same, but you can see it's broken. There's a fracture at L4 down there. And CT, of course, is the best to diagnosis. So there's a couple more images. Here's this fracture. See it there? So compare it to this one above it, L3, and you can note how that looks. And here is spondylolisthesis, the anterior. I mean, both of them we can see anterior slippage. This is L5. This is L4. Okay. L5 here, L4 there. So, spondylolysis. This is a stress fracture that happens at the pars interarticularis of lumbar vertebrae. I just want to call that the PI because it's too long to pronounce or say. But you can see it here, and you can see the fracture here, and that is lysis, splitting, breakage. Okay, now what can happen here? Instability. This thing comes moving forward. Right? There it is. The stress fracture. Boom. Slides the vertebrae forward. It's not, you know, you don't have that, support. 15% of these go on to cause this slippage, though. So most don't, but 15% will. So we talked about this, the Scotty dog, and now Scotty dog collar. It's like a little collar here. So can we all see the Scotty dog here? You can kind of see it. You can kind of see what we're looking at. You know, this is the, well, we don't need to go through all of it, but here's the dog, right? Lateral x-ray, okay? Here's a great picture of it, except I think these are flip-flopped. These are flip-flopped. But here's a fracture here. Here's our little dog, right? You can kind of see the dog here. Here's the nose of the dog. Here's the ear of the dog. Here's the feet of the dog. And here's the little tail back here. And here's this fracture, and this is just totally just destroyed here, okay? And over here, we can also see the dog. Nose, ear, you know. And there's actually, I don't know if there's a fracture there, but we're going to look at a better case in a second. All right, well, here's a good picture. It shows the ear, the head, the neck, the body, the leg, front leg, and lucency at pars. The collar is the fracture. Here's a fracture right here. It's very vague, so you have to look very close. But if you look up here, it's all just kind of, it's whatever you want to call this. Not radiolucent, but here's lucency. Little dark line, a little crack here seen, and it's like a little collar around the neck of the dog. So hopefully everyone can spot that. So that's the end of the video, but not, because we have some interesting radiopedia cases. This is spondylolysis and listhesis. So here's the collar and the slippage. Now it says anteriorly over here. So this right here, right? I can't really tell. It's very vague. but supposedly this is push anterior. I mean, I can kind of see that. But here is the defect. Let's show the defect. Okay, so can I zoom in? Okay, here we go. Let's get rid of the add. All right, so it says L5. So this is S1, this is L5. So let's look at this area back here. Okay, here's the spinous process. This is that PI, right? Pars, whatever. And look at this one on L5. It's not connected. Look at this. Connected, connected, connected. Broken. Okay, it's broken. And we can see that. It's not connected over here either. So that is not connected. So that is the Scotty Dog collar. Now here is a better example, in my opinion. So here's these normal spinous processes, but L5, right, we have this Spondylolisthesis as well, pushing outward over this S1. But L5, the spinous process here, this is L4, this is L3, there is a gap, and this is fractured. So this is, again, what's it called? Spondylolysis. And we can see it on this bone window, which shows it even better. So here's our normal, and this never connects. And you can kind of see there, it's kind of broken off here. And now a cool picture is this maximal something imaging projection, MIP. I don't know what that means. You can kind of see the dog here. Look at this. All right. Here's a better picture. Okay, look at that. Okay, so let's minimize this. Here's our fracture right there, where I'm pointing. There's actually a loose piece right there, and here's a, they're not connected here versus all these. This is a neck, and this is where their fracture is down here, and it's split off here, bilaterally actually. So this is the right side, split off here, loose bone fragment. Here's the left side, split off. And lastly, I haven't even looked at this picture. Okay, so this, you can see right there, there's that loose bone fragment. This is all one piece, nicely, and then there it's, there it is there. Maybe, no.